Yeah, good evening, friends. Welcome to Tuesday Critical Care and Emergency meetings. This has been a new normal for almost a year and a half. So today we have some interesting topic, which has been the debate of the medical fraternity and even in the common layman. So the black fungus, the mucormycosis was been named and termed as black fungus, and that made a huge buzz and news across. This fungus, like mucormycosis, been known to us for almost last 50 years to 100 years in view of it being more common in diabetes and also some of the immunocompromised food. It likes sugars, it likes acidic media, and it attacks some of the sinuses and orbit or lung or some of the parts of CNS system. That has been known to us for almost 50 years or so. But this is making a news now for the last couple of months, more compared to the last wave, causing the infections in the COVID patients, which being a pandemic related surge. So to address these issues, we have our ID specialist who has post-graduated and done his DM from infectious disease from All India Institute of Medical Science, has been a consultant in Yashoda Group of Hospitals. Dr. Mona Lisa Sao will address on those areas and enlighten all of us on that. So we will take an interactive session later on after the presentation with your questions and some debates on that. So I welcome Dr. Mona Lisa to take on. Welcome you.
Thank you, Dr. Venkatraman. Now, the talk of the whole world right now is moving from COVID to the COVID post-COVID sequelae, that is the COVID-associated mucormycosis. We shall be referring to it. It has been referred to as shortly the CAM, COVID-associated mucormycosis. We shall be dealing with the evidence as well as our own experience regarding the same. There have been multiple reports in the newspapers, like it has been making news since last a month, that it has been a cause of fear, fury among the people. It has been claiming a lot of lives and is potentially fatal. So you can see, like you can make out in everyday newspapers, seeing one or two articles about the black fungus claiming lives. So what is the black fungus? The layman has, for the layman, it has been termed as a black fungus, but actually it is a misnomer. The black fungus, it is referred so because the involved tissue by the fungus becomes black and necrosed. As this fungus, the mucormycetes, the group of fungi, the mucormycetes have a propensity for the blood vessels, and they cause angioinvasion, and the area involved becomes black and necrosed. And on gross examination, it appears as black necrotic eschar. As you can make out in the picture, there is a black necrotic eschar about the right eyelid. And on microscopy, it appears as a broad accepted hyphae. And in the cultures, it is broad accepted hyphae, but it is not black in color, as it has been named. Scientifically speaking, the true black fungi are the dermatitious fungi. They are the pigmented fungi which have melanin in their cell walls. And the fungi included in this group include the Alternaria, Cladophila, Carbuliria, Exerohylum, Cladosporium, etc. And they cause the diseases ranging from localized diseases like localized cutaneous infections to serious infections like and the life-threatening ones including cerebral abscesses, to name a few. So now, why does the COVID patients have mucormycosis? There have been multiple reasons for this, multiple factors playing intricately causing this. The major coexistent comorbidity in the patients, COVID patients, is diabetes. Diabetes itself is a pandemic, and India is the capital of diabetes of the whole world. So in the diabetic patients, they are more predisposed to mucormycosis. We shall be dealing with the reasons for this in the subsequent slides. The other reasons being the very liberal use of steroids and the immunosuppressants like tocilizumab. It contributes by causing hyperglycemia as such, and also contributes by causing immunosuppression, the suppression of the lymphocytes, the CD4 and CD8 cells, lymphopenia, and impaired neutrophil functions like chemotaxis. COVID itself is also an independent risk factor due to the certain factors which include lymphopenia, the suppression of the CD4 and CD8 T lymphocytes. The COVID-19 virus itself has a propensity for the endothelium and causes endothelitis. The raw endothelium occurs and which predisposes to various vascular thrombi. The high load of the virus also leads to the alveolar epithelial damage, which further increases the risk of invasive fungal infections in the lung parenchyma of these COVID-19 patients. There are also certain environmental factors which contribute to the high incidence of mucormycosis. It has been seen in more number of cases of mucormycosis associated with the COVID-19 have been detected in certain states, more so in certain states like Gujarat and Maharashtra. And this has been attributed to the high spore count of the molds in these areas. The geographical variations of the spore count in the various areas can be ascribed to the difference in the cases. Now coming to the immunosuppression that is caused by the COVID-19 virus itself. The COVID-19 virus causes immunosuppression by multiple mechanisms. The most important one being the lymphopenia. It causes the reduction in the CD4 and CD8 T lymphocytes and thus impairs the innate immunity. The impairment of the immunity causes the further disease process. And also there is an inflammatory cytokine surge. The inflammatory cytokines, the most important ones being the interleukin-6, and there is also increase in the ferritin levels. So the hyperferritinemia causes increased serum iron levels, which further helps as the iron is the major substrate for the mucormycetes. So increase in the serum iron levels causes more growth of the fungi. Also, there occurs the raw endothelium known as the endotheliolitis caused by the COVID-19 virus. And also there is a prothrombotic state by the direct viral infection of the endothelial cells and thus leading to the endothelial inflammation and causing the various manifestations. Also, there is an induced diabetogenic state in the COVID-19 patients. The COVID-19 virus, there have been postulated that it affects the beta cells of the pancreas and it can induce a diabetogenic state in a person who is not known previously to be a diabetic. So by these mechanisms, the COVID-19 virus causes immunosuppression. And as we all know that mucormycosis is a disease most commonly of the immunosuppressed population. Mostly the diabetics, the people on prolonged steroids, those with the malignancies, solid organ transplant patients, hematological malignancy patients, all these are predisposed. And the COVID-19 itself causing immunosuppression also predisposes to the disease. Now coming to the mechanism by which diabetes predisposes the COVID-19 patients to the mucormycosis. The most important mechanism being the impairment of the neutrophil function. In a normal individual, the mucormycosis, the mucor spores, they are of multiple sizes. The spores which are more than 10 micron in size, they get localized to the sinuses and may cause further sinusitis. And the ones which are less than 10 micron, they reach up to the alveoli. And in the alveoli, the distal alveolar macrophages, they phagocytose the conidia. And when these conidia germinate into the hyphal forms, the macrophages attack it. The neutrophils attack it. But in cases where these mechanisms of defense of our body are impaired by the glucocorticoids, hyperglycemia, conditions of acidosis and neutropenia, the body defense mechanisms are impaired and there occurs the growth of the fungus. And it further undergoes angioinvasion and the further manifestations like hemorrhage, thrombosis and necrosis to follow. The impaired neutrophil function include the impairment of chemotaxis and the transmembrane migration of the neutrophils. There is a reduced binding in the diabetic patients. There is a acidic environment in the body, the pH being less than 7.4, and in this condition, there is reduced efficacy of the transferrin and thus the serum iron levels increase, which helps as a substrate for the fungi to grow. And also there occurs an increase in the expression of the protein, glucose regulated protein 78 in the endothelium. This GRP78 is expressed on the endothelial surface of the vessels, and the mucormycosis, in presence of them, the receptor is upregulated, and it further causes binding of the fungi to the endothelial walls and angioinvasion. Also, the fungus has a ketone reductase enzyme. So, in the patients with diabetic ketoacidosis, the ketones can be used as substrate by this fungi. So, who are the patients of COVID-19 who are at higher risk of mucor? We need to be more vigilant in these cases, these patients. The patients with uncontrolled diabetes, high dose and early initiation of steroids, the individuals with lymphopenia, those with the high levels of interleukin-6 and hyperferritinemia, ones who have been given tocilizumab, those with neutropenia, and the ones with prolonged use of broad-spectrum antibiotics. These individuals are at higher risk of mucormycosis, and early diagnosis in these patients is quite essential for adequate management of the disease. Now coming to the various manifestations of mucormycosis. The mucormycosis can affect various systems of the body. The most common manifestation being the rhino-orbitocerebral, which comprises about 36% of the cases. The next common one being the pulmonary, followed by the cutaneous. The less GI mucormycosis comprises a very small, like about 7% of the cases. There are the clinical manifestations of the disease are different according to the system's manifestation. Like in the rhino-orbitocerebral mucormycosis, the most common manifestations being presentation with the nasal blockade or congestion, presence of bloody nasal discharge or blackish discharge from the nose, presence of facial pain, numbness or swelling, unilateral headache, pain in the eyes and orbit, toothache, loosening of tooth or jaw involvement. This toothache and loosening of tooth has been more seen in the people with COVID and COVID-associated mucormycosis, and was not much appreciated prior to the non-COVID era. There also occurs blurring and double vision, tingling sensation on the face, fever, and blackish skin lesions can be appreciated in the people with rhino-orbitocerebral mucormycosis. The manifestations of pulmonary mucormycosis include fever, cough, hemoptysis, chest pain, and worsening of respiratory symptoms. For the early diagnosis of the patients manifesting with the aforesaid symptoms, radiological investigations need to be undertaken. In the individuals with rhino-orbitocerebral mucormycosis, the most important investigation is the gadolinium enhanced MRI of the brain, including the orbit and the PNS. In these images, you can appreciate, in the first image, you can appreciate the T2 weighted images showing the heterogeneous enhancement of the maxillary sinus. In the second one, there is a homogeneous enhancement of the maxillary sinus. And the figure C shows the involvement of the sphenoid sinus. There are certain factors which influence the outcome in these patients, the individuals with COVID-associated mucormycosis. They include surgical, the most important one being the surgical debridement. Surgical debridement is the most essential part as it causes removal of the devitalized tissue. These fungi have a very high propensity of causing angioinvasion, and they cause microthrombi and cut off the blood supply to the particular area, causing the necrosis. So removal of the devitalized tissue is very important for allowing the drug, the antifungal that we subsequently give, to reach to the tissues. So the major role of the surgery is removal of the devitalized tissue, debulking of the infected tissue, theoretically allowing the faster action of the antifungals to be given subsequently, as they will have a lower burden of fungi to act upon, and also to establish a histopathology. And there is a definite evidence that combined medical and surgical management improves the patient outcome. These are the images of a patient of ours who presented with jaw pain and loosening of the tooth of the upper jaw about in the 3rd week of discharge after COVID. And our plastic surgeon did extensive debridement, and he did the partial maxillectomy in the case. And the patient is now on antifungals and is doing well. There is also another important factor which determines the outcome, that is the reversibility of the precipitating condition. Strict control of the glycemic control is very essential for the proper management of the disease. There should be the reversal of the diabetic ketoacidosis. Immunosuppressive agents should be stopped if they are being continued, like the steroids should be discontinued. Neutropenia, if possible, should be tried to be reversed. Also the other factors which contribute to the management of the disease include which species of mucorales have been causing the mucormycosis and the drug susceptibility. Although the species identification of every mucormycosis is not possible, it can help us to have an idea about the antifungal agents to be used and the dosage adjustment, as some of the mucormycosis species like the Cunninghamella, Absidia, Saxinia, and Apophysomyces, they have got a higher MICs to amphotericin B. Also, it has been shown in a study that the mucormycosis species, the Cunninghamella, is associated with 2.78 times fold increase in the death as compared to the other species due to a higher MIC to amphotericin B. In a multicentric study which included 12 hospitals across the country, taken up by Dr. Atul Patel from Gujarat, he included 12 centers, and the period of the study was from January 2016 to September 2017, a period of about 20 months. And they isolated the total number of cases taken into consideration was 465. The most common manifestation in them was the rhino-orbitocerebral, and the most common species of mucormycosis that was identified was the Rhizopus species. Apophysomyces was also seen in about 15% of the 15 individuals. In our cases that we saw at our center, we also saw 4 cases of dual infections caused by Aspergillus fumigatus as well as Aspergillus flavus, along with the mucormycosis species, the Rhizopus aeryzus. In this histopath image, you can make out the red arrow pointing toward the broad aseptate hyphae of the mucormycosis, as well as and the blue arrow pointing toward the thin septate hyphae of the Aspergillus. The antifungal agents which have been used are also a major determinant of the outcome. The condition of mucormycosis can be referred to as a condition of medical and surgical emergency, as urgent debridement of the involved tissue is very essential for helping the drugs to reach the site of action for in adequate amounts. The amphotericin B monotherapy has been postulated as the treatment of choice. In certain conditions, we may have to use a combination therapy, but it has its own drawbacks, like being expensive and there being the additive toxicities. Amphotericin B deoxycholate has been shown to be associated with higher mortality. There have been certain issues associated with the amphotericin B, like most of them go for slow escalation of doses of amphotericin B, which is not recommended. The slow escalation of doses has been strongly discouraged by the various guidelines. And with the liposomal ampho-B, the dose required is like 5 to 10 milligram per kg per day, and usually there occurs the underdosing due to several factors. The various other oral agents available for the mucormycosis include posaconazole and isavuconazole. Therapeutic drug monitoring may be required for these azoles, but they are not very widely available. The duration of the antifungal therapy, there have been no definite guidelines, and the therapy needs to be individualized depending upon the response to the therapy on subsequent follow-up. There are certain significant drug toxicity associated with these antifungals, which include the renal toxicities, cardiac arrhythmias, drug interactions, profound ear weakness, and poor oral intake have been associated with the use of these antifungals. The European Confederation of Medical Mycology, they have postulated the guidelines in 2019. In these guidelines, in cases of suspected and confirmed mucormycosis, they need to be considered as emergencies, and prompt action needs to be taken. The surgical debridement with clean margins is to be done, and immediate treatment initiation with the antifungals. The guideline warns against the slow escalation of doses. The appropriate dosage of liposomal amphotericin B, minimum of 5 milligram per kg, needs to be started right from the day one. If there is involvement of brain, the dosage of amphotericin B needs to be very high. That is the 10 milligram per kg of liposomal amphotericin B. In case of solid organ transplants, also higher dosage is required. If there is a pre-existing renal compromise, the drug of choice becomes the isavuconazole or the posaconazole IV. These are all the grade 2A or 1A recommendations, and these guidelines do not recommend the use of amphotericin B deoxycholate and state that it should be better avoided. And the response to the treatment needs to be assessed weekly by imaging. On weekly imaging, if there is a stable disease or a partial response, then we may continue with the first line treatment or change over to the oral treatment, which is isavuconazole or posaconazole sustained release tablets. On further imaging, if there is a progressive disease, we may continue with the liposomal ampho-B, but we need to increase the dose to up to 10 milligram per kg per day, or do a combination therapy with posaconazole, or we may change over the therapy from liposomal ampho-B to isavuconazole or posaconazole. If there is a toxicity with the liposomal ampho-B, then we need to change over to isavuconazole or posaconazole. Coming to the other determinants of the outcome, the site of infection is also very essential. It has been seen that there is a higher mortality in the cases of associated with pulmonary mucormycosis, CNS mucormycosis, and disseminated cases. There is also a higher chances of vascular complications in the involvement of the above sites. This is the CT image of a patient who had pulmonary mucormycosis, and the below one is the histopath image showing the necrotic debris in the lungs with broad septate, thick walled hyphae. In cases where there is a CNS involvement, there are certain things which need concern, because there is a poor penetration of the oral antifungals, posaconazole and isavuconazole to the site, and there needs to be given a higher dose of liposomal amphotericin B, which is 10 milligram per kg per day for a prolonged period. And also in most of the cases, surgical excision is not always possible in case of CNS involvement. The most important concern in our Indian settings is the cost factor, because for an average of 60 kilo person, the daily cost of liposomal ampho-B would come to around somewhere between 30 to 40,000 per day, and it is quite expensive. So most of the patients in India, they resort to living against medical advice. There are also certain unidentified factors which include, despite giving the correct management, there may occur adverse outcome, like occurrence of unusual species of the mucormycosis which have an higher MICs. Also, there is a persistent qualitative dysfunction of the neutrophils and macrophages, which could contribute to this. There is we try to review the literature of the COVID-associated mucormycosis up till today, and the search strategy remained the use of key terms like COVID-19 or SARS-CoV-2 and mucormycosis. We came across 63 publications which reported cases of probable or confirmed COVID-associated mucormycosis. Most of them were case reports or small case series. The most common manifestations of most of these were the rhino-orbitocerebral, and there were 3 case reports of GI mucormycosis. According to the cases reported from the country, most of the states of the country have been reporting the cases of black fungus, including Telangana. There is one of the major publications that I came across. It was published as a preprint in the Lancet, and it includes, the title of the study is The Emergence of COVID-19 Associated Mucormycosis, Analysis from 18 Countries. And in this study, it was conducted by the various countries across the world, and led by Martin Hogan, and also the scientist, the microbiologist from PGI Chandigarh, Dr. Anurag Chakravarti, is also co-author. the corresponding author of this article. In this, it undertook the study till April 12th. And in this, they identified 80 cases of COVID-associated mucormycosis. The maximum number of cases were contributed by India, like 42 cases, and followed by the USA 8 cases, Pakistan 5 cases, and the rest of the cases from the subsequent countries. In this study, the most common manifestation was the rhino-orbital mucormycosis, rhino-orbitocerebral disease, which was there in 59 of the individuals. And as we know, as you can see, the India contributed to most of the cases, about 42 of them. And the most important underlying condition in these patients was diabetes in 66 of them out of the 80. And uncontrolled diabetes was there in 53 of them. There were certain important findings in this study, which included the uncontrolled diabetes mellitus and the use of systemic corticosteroids was the major comorbid predisposing factor to the COVID-associated mucormycosis. Rhino-orbital cerebral mucormycosis is the most common, contributing to about 74% of the cases. Pulmonary mucormycosis occurred nearly in almost exclusively in the ICU settings. Amphotericin B formulations and surgery, these were the predominant treatment strategies used in these patients. Despite using of surgery and amphotericin B, the mortality rate was quite high, about 49%, and mostly it was in the cases with pulmonary and disseminated mucormycosis and cerebral disease. Of the 50% survivors, 46% of them had a major morbidity, like they had a loss of vision in 46% of the survivors, maybe unilateral or bilateral. Now, coming to our own experience, since last March 2020 to May 2021, we, the 3 centers of Yashoda, have already treated about 40,000 patients of COVID-19, 5,000 of them being with severe disease. Of them, 3 of them came back to us with mucormycosis on follow-up or developed mucormycosis in hospital, and 73 of them were referred to us with mucormycosis from the other hospitals. The cases were referred to us from the other hospitals of Hyderabad, Andhra Pradesh, Maharashtra, and Gujarat. In this period, we had only 5 cases of non-COVID mucormycosis. The epidemiological qualification included 65 males and 11 females. The age group was 33 to 70 years. The various risk factors, the most important one was the diabetes, which was present in 65 of them. 3 of them were organ transplant recipients, and 2 of them were hematological malignancy patients. No risk factors were identified in 6 of them. All of these individuals had received steroids in the treatment course, and tocilizumab had been administered in 4 of them. The duration of COVID-19 to the development of mucormycosis was about 1 to 10 weeks, and the median period of presentation was 3 weeks post-COVID detection. The most common site we detected was the rhino-orbitocerebral. It was corresponding to the world over study. Pulmonary mucormycosis was detected in 9 of them, and GI mucormycosis in 5 of them. All of the individuals were given antifungals, and surgical management was done in 65 of them. The outcomes, 9 of them succumbed to the disease and survived. 20 of them survived, and 47 of them are yet under therapy. So coming to the various challenges that we face in the management of COVID-associated mucormycosis, there are diagnostic challenges, therapeutic challenges, as well as preventive challenges. The diagnostic challenges include the rhino-orbital mucormycosis, though it is the commonest one and the easiest to diagnose, but we need an awareness, increased awareness among the doctors as well as the patients, so that they can come to us early in the initial phase of the disease, so that appropriate management can be done when the disease has not spread to the CNS or the orbits. In the pulmonary cases, it is like difficult to differentiate between the COVID disease itself, the COVID-associated pulmonary aspergillosis, and the bacterial infections. A high degree of suspicion needs to be kept in these for an early diagnosis. The clinical manifestations of GI mucormycosis are non-specific and may include abdominal pain and enterocolitis. And if these symptoms are present in an individual who has recovered from COVID, they should be more vigilant about it and should present to the doctor as early as possible. The diagnostic procedures are difficult to be undertaken in these individuals due to the sickness per se and also infection control issues. And there is one of the major diagnostic challenges that we face is the absence of a biomarker. Unlike in Aspergillus, we have the galactomannan, and for the Candida, we have the beta-D-glucan. There is an absence of any such marker in case of mucormycosis. We also have to face the therapeutic challenges, which include these patients are too sick, often too sick, to undergo an extensive source control procedures, which are the treatment modality of choice. Also, there are infection control issues in surgeries. And the medical management that we use, that is also associated with certain adverse effects like the kidney and cardiac dysfunctions. The drug interactions are also commonly seen with the azoles that we use. The preventive challenge that we face is that steroid usage is unavoidable in many of the patients. So the take-home messages include there should be a strict control of hyperglycemia in the patients, diabetic patients of COVID-19, and also there should be a reversal of diabetic ketoacidosis so that the fungus cannot derive the substrate and thrive. We should be stressing upon the limited dose and duration of the systemic steroid therapy, and it should be limited to dexamethasone about 0.1 milligram per kg per day for 5 to 10 days. And they should not be used in, the steroid should not be used in the initial week of the disease. And there should be a strict blood sugar monitoring in the post-COVID patients in diabetics as well as in non-diabetics in whom the steroids have been used. Regarding the therapy, in the individuals with limited diseases involving the paranasal sinuses, a detailed history and clinical examination should be done. Repeated cynoscopic debridement may be required in the individuals with limited diseases with about 4 to 6 weeks of liposomal amphotericin B, followed by posaconazole or isobuconazole in the consolidation phase for about 3 months. In the cases of pulmonary mucormycosis, liposomal amphotericin B is the treatment of choice, and we need to monitor the complications due to the local spread of the fungus to the adjacent structures like the pericardium, heart, vascular spread, and massive hemoptysis can occur. And also these post-COVID individuals may not be good candidates for surgical resection and arterial embolization as such. The GI mucormycosis, the manifestations being unusual GI bleed, abdominal symptoms, they should raise the concern, and they should approach the doctor as soon as possible. In cases of CNS involvement, we require a high dose of liposomal amphotericin B right from the beginning. That is about 10 milligram per kg per day. And a prolonged therapy is required, and surgical excision may not be possible in most of them. The aggressive efforts need to be undertaken right from the diagnosis to the management of the disease. It is a multidisciplinary effort, including the infectious disease, the critical care team, the ENT surgeons, the ophthalmological surgeons, the plastic surgeons, as well as the neurosurgeons working together in the medical as well as the surgical management of the cases. Source control should be done early, and adequate source control should be done so that the antifungal drugs can act to the maximum. And in the individuals with pre-existing medical conditions and the chances of poor toleration to liposomal amphotericin B, the alternative drugs like the isobuconazole or posaconazole may be preferred along with starting of liposomal amphotericin B. With this, we come to the end of the.
Thank you, Dr. Monalisa, for that elaborative and very crisp presentation. I think she brought all major issues related to the mucor in the recent times. As we already been discussing, this has been the buzz of the whole, probably in India, even in most of the setups, not only just in the medical fraternity, but in the public also. And I think we have already a few questions on the box. We will start answering them, and probably from there we will go. So again, I think there were questions. How do you suspect mucormycosis in COVID patients? How you confirm them?
the suspicion of the mucormycosis in the post-COVID patients should be high on the cards. And as we discussed, there are several clinical manifestations which indicate towards the system involved, like in case of rhino-orbitocerebral, they may present with facial pain. The various clinical signs and symptoms need to be kept in mind. And we need to go aggressive about them, like doing the radiological investigations quite early, so that we can know the extent of the disease and henceforth plan the management. Like we should be going, in case of rhino-orbitocerebral, we should be going for the MRI scan of the brain, including the PNS and the orbits, to know the extent of the disease. And the ENT people can do a diagnostic nasal endoscopy and take some samples and send for the KOH mount and also the histopath to have an early diagnosis.
Yeah. So clinical, radiological, and finally histopathological. That's how we actually sequentially confirms, as he pointed out. There were some other interesting questions on board. They were asking about the iron chelation. When you said ferritin and the high iron levels in the blood being one of the risk factors for this fungal infection, do you think that chelating iron or giving some iron chelators will help in preventing mucor in COVID patients with high ferritin levels?
The desferoxamine has been shown to increase the risk of rather mucormycosis, but the other ones like the deferriprone can be used. They have not been seen to be associated with increased risk of mucormycosis.
So you mean chelators also shown to increase the risk, not the iron itself?
No. Yes, the chelators like the desferoxamine have been shown to increase the risk.
Yeah. Any relation you found in any of your review of articles like serum ferritin, high serum ferritin has been associated with more mucor?
Yes, I came across a couple of articles which have mentioned that high serum ferritin levels along with in the individuals with the cytokine storm, they have been associated with increased risk of mucormycosis, as in the individuals with high ferritin, there is an increase in the serum iron levels, and this is a substrate for the fungus itself and causes the increased risk of mucormycosis.
Yeah. So there are other questions like, when do you suspect a disseminated mucor? What are the red flag signs for a disseminated mucor, you think?
Individual who has recovered from COVID presenting with multiple symptoms like hemoptysis and having rapidly increasing headache, swelling of the eyes, numbness and all that can indicate towards disseminated disease, including involving the lungs as well as the paranasal sinuses and orbits. Rapid progression of the symptoms can be an indicator towards the disseminated disease.
Yeah, I think that's where you said probably rapid multi-organ issues from, as you said, rhinocerebral or vital, and also lung, GI, or multiple disseminated symptoms of multi-organ failure. And there are also questions related to, if you are using a conventional M4B, how long the therapy you should be continuing post-operatively. The other part, I think I can answer, whether you need a mandatory center line. What do you think the duration of conventional M4B if somebody is using conventional M4B?
Usually the duration of amphotericin B is for about 4 to 6 weeks. But usually, mostly we see that the individuals on conventional amphotericin B, there is an increase in the serum creatinine and hypokalemia occurs. So we need to monitor these. And if there is a rise of the serum creatinine to maybe above 2, then we can give a day or 2 of drug holiday and then we can again restart. And usually the duration is about 4 to 6 weeks. And at the end, we can go for a consultation of with the posaconazole and further give the oral posaconazole for about 3 months.
Yeah, the second part of the question, was it mandatory to put a central line in administering M4B? Not required. If you have a peripherally placed line also, which sometimes we say PICC lines, which can be centrally located with peripherally placing. So those also do help us in actually giving. The main important is the duration. See, when we need a drug to be given over 4 to 6 weeks to sometimes 3 months to 6 months, we need a probably a longer line. So for that reason, we put actually peripherally placed central line for its longer duration. There is another interesting question saying, as you mentioned, the risk factors are in broad spectrum antimicrobial, along with all others. There were some questions from Dr. Prusti saying, does voriconazole use also prone to you for mucormycosis?
Yes, there have been several studies which indicate towards the occurrence of breakthrough mucormycosis in the individuals who are on voriconazole therapy, suspecting that there may be any COVID-associated aspergillosis. So in these individuals, there can be a breakthrough mucormycosis, and it should be kept a high suspicion. If the patient is worsening on the voriconazole, then we need to have consideration of the mucormycosis occurring.
Okay, GI symptoms, GI mucor symptoms. There were some questions, like you said, most of these patients may not have a very specific symptoms, but there are some GI symptoms you mentioned. So again, the same question repeated. What are the GI symptoms?
These individuals these individuals may present with fever, abdominal tenderness, and also there can occur enterocolitis in these patients. The symptoms are quite non-specific, but occurrence of any GI symptoms, which are these, should make us suspect of a probable cause of mucormycosis, and they need to get evaluated.
Yeah, similarly, we had actually a case which was transferred to us from another state, airlifted, and initially this patient was for a transplant and was on a track or was on a ECMO. And honestly, there was no GI symptoms or GI even abdominal distance and any signs of peritonitis. This patient was awake, conscious, talking to us or signaling us. So in this patient, when we just took a cuts of his CT2 just before the workup of a transplant, we got a sigmoid perforation which is concealed. And later on, this patient was undergone a laparotomy to see the causes of the sigmoid perforation and the repair of that with a colostomy. Later on, we could actually identify a angioinvasive mucormycosis in this patient. So I think many of these patients where this GI mucor has been very asymptomatic also because of probably the concealed perforations or because of many immunosuppression drugs and many things. The inflammation also not been so evident in many of them. And we land up into multi-organ failure and die. We don't know whether it is a bacterial, fungal, and or a mucor in them also. So GI can be very silent. GI mucor can be very silent killer in many of them. So after actually we got the histopathology, then only we could actually identify in this case. There another question that in a non-diabetic case and a COVID positive, how should we actually suspect fungal infection? Any early signs? How long we should need to be observing and keeping watch for an early sign in them?
The usual median period of manifestation of the post-COVID mucormycosis is 3 weeks, and it can range from as early as 1 week to as late as 10 weeks. So we need to be monitoring the blood sugars in the individuals, even those who are not non-diabetics, but were administered steroids. So in them, we should be monitoring the glucose maybe every alternate day to keep an eye. And any uncontrolled sugar should be managed adequately. And if these the signs and symptoms are usually the same in the cases of diabetics as well as non-diabetics. And as we have already discussed, these signs and symptoms should alert the clinician that this could be mucormycosis, be it diabetic or a non-diabetic. But the most of the patients are diabetics.
Yeah, there is another question that what is the best drug for disseminated mucor?
The best drug for all of the cases of mucormycosis is liposomal amphotericin B. But in case of disseminated cases, we may go for a combination therapy with isobuconazole or posaconazole along with the higher doses of liposomal amphotericin B.
Is it contagious to healthcare workers?
Most of the disease, the mucormycosis is not contagious. It does not spread from person to person. As we know that the fungus is ubiquitous. It's there everywhere in the soil, in the air, spores are there. But it does not cause disease in the immunocompetent individuals. The immunocompromised ones are the who are more predisposed to it.
There were a lot of questions related to methylcobalamin. Is it effective in preventing mucor?
I have not come across any of the studies which says that it is protective against mucor. I'm
actually surprised to see there are many questions related to methylcobalamin. I have seen many social media messages and text circulated among us with a photo shoot of a methylene blue put onto a oxygen humidifier, and that been used as a preventive measure to prevent mucormycosis. None of them have any scientific evidence to support those things. Uncontrolled sugar secondary to steroid usage in non-diabetic patient, even for a short period of time, do you think that also still increases the risk of mucor in them?
It can, because most of the cases, like the steroids are used very liberally, but even in the individuals who are given short courses of steroids, we need to be like vigilant. There may be cases.
This has been a common phenomenon we see on many pre-diabetic patient, even non-diabetic patient, when they receive their steroid shots, we see their sugars shoot up for a day or 2 or 3, or during their hospital stay at least, and probably later on they settle down. But we have actually come across few cases even in our hospital where they were probably pre-diabetic or dysglycemic during the hospitalization, but later on not much of a high glycemic status during their post-hospital stay. Still they got mucormycosis. So there may be, as you rightly pointed out, there may be many reasons for this COVID related. One of them, as you pointed out, is glycemia related, but as you said, CD4, CD8, both cells coming down, neutropenia, leukopenia, lymphopenia, and many maybe chemotaxis, neutrophilic migrations. Maybe we don't know, many hypothetical things are thrown, but maybe there are many underlying things which are unanswered yet. So how do actually you identify the species?
The identification of the species is usually a microscopic diagnosis. The cultures, the gross appearance on the culture plates is different for the different species, like the different colors of the tubes and the plates. And further on the microscopy, in the KOH mount we cannot make out, like immediately when the sample comes, they do the KOH mount. Only in that KOH mount we can appreciate the broad separate hyphae, which tells that it is a zygomyces, but speciation cannot be done. Speciation can be done only after the cultures, and the PCRs that are there, they are not widely available for the identification. It is mostly after growth of the fungus in the culture media that we can identify microscopically.
How do you actually know the resistance pattern? You mentioned few of the species are mostly difficult to treat and they may have a higher mortality. So do we do that resistance pattern in India or somewhere?
No, the resistance pattern is done at the apex centers like the PGI and VPCI at Delhi. Like if we know, we can, by the different morphological appearances under the microscope, the various species can be identified. And it has already been established that certain species like the Cunningham and Absidia, they've got higher MICs. So if we identify these fungi with the higher MICs, these fungi, these species of mucor, then we need to use higher doses of liposomal amphob in these cases.
There is again, I think the practical question. Now we are in scarcity of amphotericin B. So how are you handling? What is the other alternatives available, and you will suggest us for that?
We are also facing the scarcity of the drug, but most of our patients are able to procure it. We got liposomal amphotericin B is not much available, but the deoxycholate form is available. And along with that, we use the higher dosage of posaconazole or isavuconazole in these patients for the management, along with the surgical management.
So do you think this mucor being more common in this second wave than the first wave? The cases has been gone up, and this news was not so prominent in the first wave. Even we had the 3 months of last July, August, September. But this time the buzz was more. There is a lot of news in and around, including the media has been in a part of it. So do you think this been a more number of cases in this wave, and any reasons for that you think?
As such, the number of cases of COVID-19 itself has increased, and maybe like it was in the last wave, it was the maximum was around 1 lakh, and in this wave, it is around 4 to 5 times of that. As such, the cases have increased. The more number of younger individuals have been involved in this wave, and the mutant viruses, they can be ascribed to causing some more immunosuppression in the patients, which predisposes to the mucormycosis in this wave. That could be ascribed to it. And the more liberal use of the corticosteroids in this wave.
I think over-the-counter corticosteroid use was much less in the first wave. Yeah. So as we understand it, the disease process more now, I think over-the-counter for all mild to moderate disease from rural, even if you see the government kits, it includes corticosteroids nowadays. So that may be another reason the usage of corticosteroid adding to the increased number of cases may be contributing to this increase. Dr. Mona Lisa, is it been a nosocomial infection? Can this be a nosocomial infection like what we see with GNBs, GPCs? Can this fungal be a nosocomial?
There have been reported cases of mucormycosis which can be nosocomial, but the most common manifestation of the nosocomial is the skin mucormycosis and the GI mucormycosis. And they have been associated with the mostly post-surgical individuals and those with the bag, colostomy bags or any devices in situ. So these are the individuals who have the nosocomial or hospital-acquired mucormycosis, but it doesn't occur from the person to person or like the other GNBs when there is a lags in the infection control measures. These doesn't occur.
Okay, you already pointed out that we don't get mucormycosis from a patient, healthcare workers. So you also pointed out that it may not be transmissible from one patient to other patient. So this is not like an outbreak or a kind of thing which can happen in your hospital, which has been. The other common actually allegation being the humidified oxygen, the water used in humidified oxygen. And that's where I think many images came out with methylene blue. So do you think that can be a source in spreading the spores?
Not much of it, but we should be using the sterile water in the oxygen therapy, as it may contribute to the increased number of cases of mucormycosis, though definitive evidence is not yet there.
So you put some images saying the geographically Gujarat and other parts where you see a major part of the disease burden, the mucor related cases, having more probably spores of mucor. Does that also holds good as a country, India? Because many of your studies, when you saw the major contributors for mucor being India, whereas we see blastomycosis or other things which we don't see much in India. Is it been India being more common for this fungal disease because of its more spores?
Yeah, the presence of the spores in the environment of the India is definitely more than those of the West. And India, in most of the studies that you see, which includes even in the pre-COVID times, most of the studies which include multi-centric studies across the world, India has been the major contributor in most of the studies, accounting to more than 50% of all the cases of mucormycosis. So definitely it is the spore count in the soil and everywhere in India that contributes majorly to it.
So many of us, including bureaucrats, politicians, hospital authorities, clinicians, primary doctors, intensivists, ID physicians, all are worried about it. That's for sure. And we are all probably scared in a situation where we have a shortage of antifungals, we have a load of COVID cases. So what do you think your action plan will be to prevent and protect or probably drop the number of mucor cases? As a ID clinician, what will be your guidance, suggestions, or recommendation to prevent this mucor in current pandemic?
One of the important things would be, like in cases of mild disease and in the first week, we should avoid using steroids. Decreasing the steroid usage can help. And early suspicion and early diagnosis is the key to treatment. So key to successful treatment. So we should be using not using the steroid very liberally, strict glycemic control in the individuals who are diabetics, keeping the clinical signs and symptoms in mind, and making the public aware about it, so that even if they have the early symptoms, they can come to us and we can manage it adequately and in early time, so that we have a successful outcome.
So appropriate duration of steroids, probably as you pointed out, 5 to 10 days, and probably later on dropping it when it is not required. You're crossing your inflammatory phase. Many prescription we see the steroid has been continued for weeks together, probably that predisposed to it, and unwanted higher dose of steroids unindicatedly may be another risk factor, and glycemic control and probably a environment with adequate precautions and optimization. Maybe these are the only things which we can do. And COVID-related lymphopenia and that related drop in CD4, CD8 count, probably reversing them back in the later phase will be a challenge. So again, there are some questions like, is it a ubiquitous fungus? Dusty environment has something to do with it with more spread in India?
Yeah, we have been aware of this fungus like for decades, and it is a ubiquitous fungus, definitely present in the soil, in the air. The spores are around everywhere, and they get lodged in the various parts. Like when we inhale, they get lodged in the nostrils, and the ones which are very small, they get like less than 10 micron. They reach up to the alveoli. But in a normal immunocompetent individual, it is taken care of. But certain individuals who are working in deep excavation areas or deep cave areas where there is a high spore load, even the immunocompetent individuals may develop the disease. So it is quite well known that a ubiquitous fungus definitely, and if we can decrease the exposure to spore, like it can help us.
Okay. There was a question like in a case of salvage therapy, we have any role of dual therapy? Even though it's not a standard, but during in a salvage therapy, you combine amphotericin B with one of these azoles, as you discussed, either a isuvoconazole or a posaconazole. Is that the process, or do you actually jack up your dosing for 5 to 10? What will be your probably what is your action in that when you actually need a salvage therapy, patient not responding?
Like in the individual, we should initially start with the high doses of liposomal amphotericin B and should not be slowly escalating the doses. We should begin with the appropriate dose, like 5 milligram to 10 milligram per kg, right from the beginning. And and when we go for the salvage therapy, like after 4 to 6 weeks of liposomal ampho B, when we are to switch over to the oral drugs, we need an overlap period of about 4 to 5 days of both posaconazole and the liposomal ampho B, as the blood levels of posaconazole come after a few days. It takes. So for that period of overlap, there needs to be both the drugs given. And in cases of disseminated mucormycosis, we may upfront go for combination therapies, as in also with liposomal amphotericin B, there are cases of derangement of the renal functions. So we may have to give a day or two of drug holiday in those cases. So during the periods of drug holiday, the other drug that is given combination can take care of. So we may go for dual therapy in.
So in CNS mucor with disseminated situations, it is recommended to go with directly 10 milligram per kilogram, not to start with 5 and increase. And in other situations, you start with 5 milligram per kilo, and probably addition when you face probably a failure or non-responders, as that chart also flowchart mentions. That's what has been actually tried to be explained. The other question is betadine spray and gurgle use as a precaution. Will it help?
It may help, like definitely not decrease the fungal load or anything, but it can help in decreasing the bacterial load as such in the oral cavity.
Is there any vaccine for mucormycosis?
Not yet.
Expecting any vaccine? No.
Maybe
we are expecting a vaccine for COVID first.
COVID, that's the concern right now.
I think this has been actually an enlightening session. We do understand there is a lot of not just the case numbers of COVID, but muco cases from the even districts, local centers, and other states which are actually flying towards Hyderabad, looking towards our city, our hospitals, to help them and protect them. And the important thing is early detection, and probably before that also preventing the COVID patients to get this mucor. As we all know, it is impossible to protect us because the spores will be in the environment and in the soil, and it is ubiquitous. So now many of us use masks. I don't understand, in spite of now at least there is a 50-70% of compliance to the mask in an appropriate way. In spite of that, these spores do enter to our sinuses, or we don't know whether this has been already in place or is a part of our respiratory system. Do you think, in spite of the masks, so why do we see so much of mucor? Is that been already indigenous to us? They are all being living with us, and this COVID is precipitating them?
it is like a ubiquitous fungus, and it is there in the air, in the soil, everywhere. So we have been living with the fungus, but when our immunity gets down due to the several factors in the disease per se, as well as the medications and the uncontrolled diabetes and all such things, so we become more predisposed to the disease. But it has always been there, and a condition of immunocompromise increases the risk of getting the disease.
Yeah. So first is, as you rightly pointed out, prevent it by using steroid judiciously and appropriate doses and appropriate duration. And during their stay, make sure that your glycemic control is appropriate, and try to be keeping them euglycemic during their hospital stay, and also keep a very close follow-up of their glycemic state, whether there is diabetic, pre-diabetic, or dysglycemia during this steroid therapy. And probably keeping a close follow-up of for their possibilities of mucus symptoms. Explain them when you are discharging them related to either rhino or orbital or cerebral mucormycosis related symptoms, and if any progression in spite of COVID recovery in hypoxemia or lung cirrhosis, other than bacteria or other after antimicrobial therapy, if the patients persist, so fungus should be kept in mind. And early diagnosis, as rightly pointed out, by a proper awareness, not just to you, to the family members, because sometimes conjunctival congestion, conjunctival chemosis, tearing of eyes may be considered normal in COVID, but when this causes a swelling, redness, pain, retroorbital headache, and the nasal discharges, and all these whatever signs, symptoms should be educated to the families or the patients. And once these symptoms has been picked up early, then we need to be very, very, very particular in surgical debridement. We see COVID being a hindrance in view of aggressive surgical debridement, not for ENT, for any department, because if it's a highly infectious net. But over 1.5 years, I think our surgeons being acquainted with surgical skills and what is being ready and prepared for endoscopies and FEST surgeries or a extensive debridement on them. And probably early enucleation or aggressive debridement can save lives and save these organs to go from there. And now we are facing a challenge of antifungals, which is being none of our control, but we have only can prevent this mucor to happen. And currently with the unavailability of liposomal amphotericin B adequately, probably further prolong the duration, and that will become a bigger challenge for us. Many of us, including Dr. Mona Lisa, pointed out that isavuconazole and posaconazole been used as an alternative, but the liposomal amphotericin remained to be the choice. Some of the times we are forced to use conventional deoxycholate ampho-B when the liposomal is not available. Our experience with the isavuconazole and posaconazole with a good surgical debridement in these situations also remain to be satisfactory and good, but it probably need a longer time to comment on that. I think with this, I thank Dr. Mona Lisa in bringing this topic and enlightening all of us with so many scientific answers on this aspect. And I thank all the participants who participated in this CME, spending their time. I think it was a learning experience for all of us. And I thank all of you and conclude the session. Thank you, Dr. Mona Lisa.
Thank you.